Thank you all for joining today's webinar, Public Health Department Accreditation to Advance Optimal Health for All. This webinar is facilitated by the Association of State and Territorial Health Officials, or ASTO, with support and funding from the Centers for Disease Control and Prevention, Office of State, Territorial, Local, and Tribal Support, and CDC's Office of Minority Health and Health Equity. My name is Claire Rudolph, and I am the Director of Health Equity at ASTO. My colleague, Leah Silva, ASTO's Director of State and Territorial Performance Improvement, and I will co-facilitate this webinar and will be monitoring the chat box throughout the webinar. So please let us know if you have any questions as we move along. The webinar slides, along with full biographies of all of the speakers, will be sent out to participants after the webinar. For those of you who are not familiar with ASTO, we are the national nonprofit organization representing state public health agencies in the U.S., U.S. territories, and freely associated states, and the District of Columbia. Our mission is to transform public health within states, territories, and freely associated states to help members dramatically improve health and wellness. This is just a visual representation. Again, we represent state and territorial health agencies in the entire country and all of our freely associated states. For today's webinar, we have convened 4 accomplished speakers from various agencies and organizations to share their health equity and accreditation experiences. By the end of the webinar, we hope that participants will be able to explain the importance of health equity to the Public Health Accreditation Board's accreditation, provide specific examples of how state health agencies have used their health equity activities to support their accreditation, and describe federal leadership on state accreditation and health equity activities. After these brief welcome and introduction remarks, Leah and I will provide a brief overview of ASTO's health equity and accreditation work, and we will be hearing from Robin Wilcox, Chief Program Officer at the Public Health Accreditation Board, or PHAB, and she will discuss the importance of health equity to the accreditation process. Liza Corso is the Senior Advisor for Public Health Practice and Accreditation at CDC, OSTLTS, and she'll present about federal support for state accreditation activities. We also have the pleasure of learning from 2 practitioners at 2 different state health agencies. We'll be hearing from Dr. Raul Gupta, the Commissioner and State Health Officer in West Virginia, and Kristen Sullivan, the Public Health Systems Improvement at the Connecticut Department of Health. They'll both be sharing how their health departments have incorporated health equity into the accreditation process. And we'll also have some time at the end for question and answers. And I'm going to turn it over to Leah.
Good afternoon, everyone. As Claire mentioned, my name is Leah Silva. I'm the Director of State and Territorial Performance Improvement at ASTO. I have the pleasure of working on our performance improvement, or our performance and quality team at ASTO. And I just wanted to give you a brief overview of the work that we do, starting with the why. Why do we support states in performance improvement, quality improvement, and accreditation activities? It's because we believe in high-performing and accountable public health agencies. To support this why, we help states strengthen the public health infrastructure, build internal capacity, and communicate the value of public health. And to help with the how, we do a number of activities. We provide technical assistance to states, territories, and freely associated states around performance management, quality improvement, and accreditation. We convene peer networks. Some of them are our Accredited States Learning Community, our Accreditation Coordinator Learning Community, and our Performance Management and Quality Improvement Peer Network. We provide documentation examples for public health accreditation, and we also develop resources and toolkits to support this work, mostly within state and state and territorial health agencies, but all of our resources and toolkits are applicable for all levels of public health agencies. And the map here on the screen is just an example of the states who have applied and received the opportunity to receive technical assistance from ASTO in the areas of performance management, quality improvement, and accreditation. And I'll turn it back over to Claire.
So ASTO's health equity work is really founded in the belief, the why here is a little bit longer than the previous slide, but we think it's really important to include to really drive home that we do believe in addressing avoidable inequities for all groups, with a focus on those who have experienced socioeconomic disadvantage or historical injustice, so that all people and communities feel empowered to achieve the highest level of health. And that is the backbone of our work at ASTO and all of our work, and especially our health equity portfolio. We also work to build the internal capacity of our members. We try to communicate the value of health equity to public health. We provide technical assistance to states through strategic planning, providing different resources and tools to support states in incorporating health equity into all of their programs and policies. And in 2016, our ASTO's President's Challenge was focused around health equity, around the triple aim of health equity, which is depicted here.
So we will get our webinar started. I have the pleasure of introducing Robin Wilcox, Chief Program Officer at the Public Health Accreditation Board, or PHAB. She will be discussing the importance of health equity to the accreditation process. Ms. Wilcox manages the implementation of the accreditation process for public health departments at PHAB. She previously worked in the Pennsylvania Department of Health for 15 years in positions that included Director of the Office of Policy, Planning, and Evaluation and Deputy Secretary for Community Health. She has also served as Vice President of the Pennsylvania Institute for Healthy Communities and as the Executive Director of a 5-county health policy and planning agency in southern New Jersey. We had to cut down all of our bios for our speakers because they were so long and impressive. So again, full bios will be sent out to the group, but I'd like to turn it over to Robin to start.
Thank you so much, and thank you for inviting me to speak with you today. Just as a little bit of background, PHAB, as you've heard, the Public Health Accreditation Board, is the organization that's responsible and has the authority to accredit governmental public health departments. And what that means is simply that we've established a set of nationally recognized standards, and then we go through a process of, it's a peer review process of assessing health departments against those standards, and if they meet the standards, recognize their achievement for a 5-year period. There are currently 190 health departments in the United States that are accredited, 27 state health departments. There's actually 26 state health departments and an integrated system. I was asked to address just briefly the value of accreditation. And we have on contract an external evaluator who surveys accredited health departments. And what we've heard from those health departments is that they've seen a significant value in the process of accreditation around their quality improvement, that the entire process of seeking accreditation stimulates continuous quality improvement and performance management and performance improvement. They've also noted that the meeting the standards and measures has improved their relationship with the community, and partnerships are very, very important to both PHAB standards and measures and to health equity. They've also talked about accountability, specifically accountability to their community and accountability to their external stakeholders. And the entire process has helped them identify their strengths and weaknesses so that they can better address particularly their opportunities for improvement. So let's talk a little bit about health equity and public health accreditation. I find it's easier to define health inequity than health equity, and that's differences in population health status and mortality rates that are systematic, they're patterned, they're unfair and unjust, and they're actionable. So we're not really talking about disparities as much as the community characteristics that create those disparities. So, for example, it's not about a specific population or subpopulation that suffers from obesity. Once you identify that population that suffers from obesity, then it's about what is happening in the community, in the environment that's promoting that obesity. It could be a plethora of fast food places or neighborhoods where there's no safe place to exercise, or just a lack of knowledge or social norms of eating healthful foods. So that means that to address health equity, health departments need to look at high-level policies and how the community changes. So rather than address that obese population and try to educate them and tell them to eat differently, it's how do we look at structural issues in our community. the systems that are in place, the economic and political systems? What about the institutions in our community, the education and healthcare, and how can those institutions change to promote healthful eating and decrease obesity? And also intra and interpersonal relations in the community, for example, racism. I would also add social capital and community resilience or community efficacy to make changes around particularly the allocation of power and resources and who makes decisions and who has input into those decisions. So that means that for health departments, they really need to have a set of specific skills and tools, and collaboration skills and tools, and leadership. If they're going to address those higher level issues about the community, they need to know how to partner with others, advocate for populations, particularly negotiate, enable those that in the power balance have less power, and mediate issues. Leadership skills are very critical for dealing with health equity in terms of mobilizing the community and then mobilizing the community around some vision and coalescing them, and importantly leading from behind, not always being in the forefront and taking all of the credit, but mobilizing the community and then leading from behind. So let's talk a little bit specifically about the PHAB Standards and Measures and how they address health equity. We organize our standards and measures within the 10 essential public health services. We do have a process of peer reviewers that look at the health departments and whether they meet those standards and measures. We've been through 2 versions of standards and measures for initial accreditation. We're working from version 1.5 now, and then we have another set of standards and measures for health departments that will be seeking reaccreditation after their 5 years of initial accreditation. And I think it's important to note relative to the PHAB accreditation is that it's not just the standards and measures that promote continuous quality improvement and improved performance management, but the entire process that health departments go through to seek accreditation. So let me talk just a little bit about how we got to where we are with health equity in our standards and measures. In our version 1.0, we included the tools that health departments need to address health equities. So our standards and measures talked a lot about partnership and collaboration, requirements for coalitions and organizing other groups, sharing data and information so that it's not just the health department's data, it's the community's data, and the community owns it and can act on it, and to actually use that data to inform public policies and process and programs, and to engage the whole community in policy development. The term health equity, though, actually appeared in version 1.0 only one time, and it was when we were talking about the community health assessment. And we said a health department has to have a community health assessment, and it must include a description of contributing causes of community health issues that include health status disparities, health equity, and high health risk populations that must be addressed in the assessment. So we really pumped up or increased our emphasis on health equity when we released version 1.5 of the standards and measures. Throughout the standards and measures, we use the term populations at higher risk for poorer health outcomes as sort of a key word for health equity. Our advisory committee thought the term health equity might be a little bit of a political hot button, so we do use health equity a lot through the standards and measures version 1.5, but there's also, you'll see many, many more times the term populations at higher risks for poorer health outcomes. We also added a measure that's specific to health equity that I'll talk about in a minute. I went in and did a word search, and we talked about health equity or inequity 47 times in our standards and measures. And then we incorporated those tools for health equity throughout the standards and measures in a number of measures. So the new measure that was specific to health equity is that health departments have to show efforts that specifically address the factors that contribute to, and again, it's those specific populations that are at higher risk for poorer health outcomes, and that they need to analyze the factors that contribute to that. They need to develop public health efforts to address the identified community factors that contribute to those issues. So again, we're getting at the community level kinds of interventions. And that they need internal policies and procedures to make sure that whatever programs or interventions or projects that they do include specific efforts to address specific populations at higher risk for poorer health outcomes. Health departments must provide a policy or procedure that demonstrates how health equity is incorporated as a goal into those policies, processes, and programs. We ask that they assess the health department's cultural competence and knowledge of health equity, and health equity and cultural competence training for health department staff is required. And that's really important in terms of going back and looking at those skills and tools. You need to start with, do our staff have the skills that are required to address health equity? So the whole workforce development piece is an important piece for health departments. Now for the reaccreditation standards and measures, they cover the same topics as the topics in version 1.5, but they're formulated very, very differently. Rather than examples of what the health department does, we've asked in reaccreditation that health departments provide us with written descriptions or narratives of how they do what they do. And in those measures, standards and measures and the requirements, we've really increased the emphasis both around the skills and tools for health equity and the requirements to specifically address health equity. So just for an example, in Measure 4.1, there's a specific requirement that the health department have on a regular basis as just a normal operating way that they operate, cross-sector collaboration and network, that it's routine in how they do things, how they collaborate with other sectors, how they mobilize and coordinate community assets, because you need to look at the assets in the community in order to incorporate community changes and encourage and advocate for community level changes and to promote community change through collaboration. Measure 5.1 really increased the emphasis around the role of the health department as the leader, the public health leader in the community. And the measure is that the health department is the strategic community health development organization, that they play that role in their community. And through that, they do cultural competence and health equity engagement to advance health departments, that public health policy incorporates, that should be health equity considerations and public health considerations, and that they incorporate evidence-based practice, cultural competence, and health equity. So that's a quick review of where we are with incorporating specific requirements around health equity in our standards and measures. I would just like to say in a summary sort of way that the whole issue of health equity is incredibly important to PHAB and important in the standards and measures, and we really look at those issues when we're looking at health departments' documentation or narratives for either initial accreditation or reaccreditation. So thank you very much, and I'll turn it back over to ASTHO.
Thank you so much, Robin. We really appreciated hearing about the value of accreditation for public health agencies, as well as learning more about the the evolution of the measures and how they address health equity. Our next presenter is Liza Corso. She is the Senior Advisor for Public Health Practice and Accreditation, the Division of Public Health Performance Improvement in the Office for State, Tribal, Local, and Territorial Support at CDC. Liza has more than 20 years of experience working in federal, national, and local organizations. She has been involved in numerous public health infrastructure initiatives and has played leadership roles in the development and support of the National Accreditation Program for Public Health Departments and National Public Health Performance Standards. Liza was also responsible for developing assessment and planning tools at NACCHO. So thank you so much, Liza, for joining us. I will turn it over to you.
Thank you so much, and thank you also for the opportunity to speak on today's webinar. It's a great opportunity to be able to discuss what CDC has been doing both to support accreditation and health equity, and I think I hope what I'll share nicely builds on what you just heard from Robin, because what we're doing from CDC certainly advances and tells not just how we're supporting PHAB and the work that they're doing and what we're seeing in the field as a result of accreditation, but how we're trying to advance it through the accreditation readiness supports that we're able to put in place directly with the field. So you heard from Robin a little bit about what PHAB is all about, and I want to emphasize the role that we do play and also serve as a co-funder with Robert Wood Johnson Foundation. The two organizations, CDC and RWJ, are PHAB's two primary co-funders. So the work that Robin mentioned in advancing and developing those standards, that's something we've been really pleased to play a role in. But we also support a lot on the flip side of the coin, and many of the states or hopefully all of the states on the call will hopefully have some recognition or familiarity with some of what I'm sharing. Certainly, funding important organizations like ASTO and NACCHO, who serves local health departments, and the National Indian Health Board and other organizations, they play such important roles in providing technical assistance and supports, and I think our CDC investments are really important in that area. We do have some direct dollars that go through some of these organizations for what we refer to as an accreditation support initiative, and many of the projects that end up supporting, getting support through our ASI accreditation support initiative activities, I think really connect nicely to health equity activities. So I'll mention a little bit about that. But so we also, and although this is over, unfortunately the funding for this ended, we also, of course, supported the National Public Health Improvement Initiative, and that, although it was 4 years of funding, it was right as PHAB was initially launching the accreditation program, which I think really jump-started many states and locals, and especially some of the larger locals, activities in accreditation and in meeting the standards and in doing some of the big areas that were needed for accreditation readiness, because we really built a lot of that cooperative agreement around the national standards and those national expectations. I think peer networks and learning communities and trainings are also important, but I also want to mention the role that we play in, and I think CDC has a unique opportunity to do this, but in institutionalizing accreditation into public health and the categorical programs. So we've tried to identify connections to some of the areas of work that are supported through our categorical areas or through our different centers, institutes, and offices. So where are the connections between what our chronic disease investments support or environmental health, and how does that relate to standards, the national standards, and ensuring our project officers are well aware of the value of accreditation and the value of an accredited health department as a grantee. In addition to connecting to different CDC-supported categorical areas, we connect to some of our similar cross-cutting areas, and that includes the Office of Minority Health and Health Equity. And we have a really nice partnership with them in terms of looking at some of the common areas of interest and how accreditation is advancing health equity, and also how we can take what is being learned and used to describe the advancement towards health equity and draw that into the work we're doing in health department accreditation. And a great example of that is just a month or two ago, we have a Health Disparity Subcommittee, which is a standing federal advisory committee that is right under our advisory committee to the CDC director. And I spoke, and a good portion of that agenda was around the connection between health department and accreditation and health equity. And I think that's a really nice opportunity to then get right to the advisory committee, to the CDC director, and what can CDC as a whole really do to advance these topics. Robin mentioned a little bit of what is going on through the standards and what those standards represent, but I want to talk a little bit about some of what we see as the big areas of accreditation readiness, because that's where I think there are a lot of good connections to health equity. So, for example, as a result of needing to address standards around health assessment and health improvement planning, although much work had been done prior to the launch of accreditation, I think the standards that have been developed and updated through version 1.5 have really raised the appreciation of the field in terms of just how much stakeholder involvement is needed and just how much and how thorough health departments and their partners need to be in looking at different populations and looking at health issues, and that has really drawn in and raised the opportunity for health assessments and health improvement plans to truly advance health equity. Similarly, the Workforce Development Plan, I think, is another great example, because that includes some real needs for including cultural and linguistic appropriate training and health equity training among staff, and really understanding what's needed to strengthen the structure of a health department and the capacities of the health department. So looking at that other side in terms of how are we advancing health equity, I wanted to share this graphic. This is something that is actually on the website at CDC and shared from my colleagues at the Office of Minority Health and Health Equity. And it represents a framework, or rather principles, that intend to lead us to better health equity. And what I think is really good to point out about this is that the 4 key areas I outlined here also nicely align with where the PHAB accreditation standards also advance health equity. So, for example, infrastructure. You heard Robin talk a little bit about the need for health departments to have policies and practices, and many health departments, for example, have developed health equity councils. I think that organizational infrastructure and organizational structure speaks to that bottom line of the graphic. Right up the middle, measurement, the need for health assessments to really include health equity data and to really look closely at health disparities. Policy, similarly, in the standards and measures that address policy, there's a need, as outlined in the PHAB standards, to look at how those policies may address certain populations. And similarly with programs, as health departments are designing and implementing health education and health protection programs, they really need to be working with the populations they intend to reach and really understand how the programs how those health education or health promotion activities really would address those health inequities. So I think those are just 4 examples that nicely show those different categories. I want to talk a little bit about what's been going on in the field, because I think it's a great example of how health equity is being advanced. The health assessment and health improvement plans, I mentioned this. PHAB did an analysis of some of those early CHAs and CHIPs. This included both from the state and local health department that were part of the earliest to be accredited. So these were version 1.0 standards, those that use version 1.0 standards. And if you look at this, I won't talk about all the data in the interest of time, but almost 70% of the community health improvement plans included indicators addressing the social determinants of health or health equity. And you can see the different kinds of partners that were part of those processes. Similarly, looking at some of those measures that really advance health equity, like health education, health promotion, or the processes, programs, and interventions, it's really a fairly high proportion of health departments that are meeting those standards. And this, again, comes from version 1.0, equally positive results are already coming through, and those that are using version 1.5. But because of the smaller data available, we can best show the data from those that use version 1.0. Robin didn't mention the annual reports, but accredited sites also do need to report annually to PHAB to show that they're continuing to make progress and continuing to give attention, and also share, big changes that may have happened. I think it's really exciting to see that 78% of the accredited health departments indicate they've been working on health equity. And many of those reports go into further detail and talk about their work that they're doing with other partners, or the in-depth analyses they're doing, or how they're working with different communities or different sectors. The outside evaluations that have been done, I think, also help to frame the opportunity for accreditation. And I love the second quote on this slide, because I really do think it represents what accreditation has to offer, that it's really a great leverage point to help advance what needs to be done. One of the best leverage points to improve the public health system and success on objective health measures. And I think that's really what it does to advancing health equity in particular. As it relates to what has been occurring in the field, and this webinar is a great example, and you're about to hear from two peers that will certainly be sharing some wonderful experiences. We've really been seeing health equity as a major topic at many performance improvement meetings. It was very much showcased at the Public Health Improvement Training that we just sponsored this past week, and it's certainly a popular query on our Public Health Performance Improvement Network exchange and in other accreditation coordinator learning communities. And so if any of you are interested in support or having more exchange, know that there are many learning communities or opportunities where you may be able to interact with others. And I'll just finish with this slide, which when you see later on, you can perhaps use to link to some additional sources, including our CDC accreditation webpage and some other partner pages. So with that, I will end in the interest of time and send it back to you, ASTO. Thank you very much.
Thank you so much, Liza. It was really great to learn more about CDC's role in supporting accreditation, and it's wonderful to hear just how many public health departments are engaged in health equity work as a result of their accreditation efforts. So thank you so much for sharing that. Our next presenter is Dr. Rahul Gupta, the Commissioner and State Health Officer in the Bureau for Public Health in the West Virginia Department of Health and Human Services. Dr. Gupta is a practicing internist with multiple faculty positions at the West Virginia University School of Public Health, the University of Charleston School of Pharmacy, and the Harvard University T.H. Chan School of Public Health. He serves as the Secretary of the West Virginia Board of Medicine and was elected to serve as the President of the West Virginia State Medical Association. He is also an engaged member of ASTO, serving as the Chair of the Prevention Policy Committee and Chair of the ASTO Tobacco Issues Forum. He's also a former member of the National Association of County and City Health Officials Board of Directors. Dr. Gupta?
Thank you very much for having me, and I want to start by thanking my co-panelists for this very important discussion, and a special thanks goes out to Leah, Claire, and the ASTO team that have made this possible. As we start to move forward, I want to just talk about a little bit about my roles, because that's relevant to working at the local and then now at the state level. So I really started to think about this several years ago as a local health officer. And as we moved forward discussing this, one of the challenges we saw was it's often a balancing act. As we embarked upon the idea of being nationally accredited at a local health department in West Virginia, the really balancing act was between understanding health equity and at the same time being able to address health disparities. We knew at the time, and I'm talking about in the range of 2010 and 11, that the look at health disparities from that angle, we're not going to be able to have the complete view of health equity in the sense of socioeconomic status, education, some of the ethnic and racial disparities, spatial disparities that often happen in rural states, LGBTQIA disparities and challenges, as well as environmental influences. So we knew that in order for us to develop a community health assessment at the time, we must look at from a lens beyond health disparities, encompassing the social determinants of health. So as we embarked upon developing the assessment, as well as the community health profile and improvement plan eventually, we started to work within community groups as well as in partnerships to enact some of these the issues that were being identified. For example, food deserts, looking at really use of school facilities after hours and helping change the state legislature, state law to be able to enact some of that. Work with our Board of Education to put in effect some of the healthy food policies for school systems across the state. Clean indoor air policies. So a wide variety of things that we're looking at are having, in terms of social determinants, an impact from a health equity that were then far-reaching, but also eventually having impact on reducing health disparities. One of the things we also did in this time was helped the legislature create an Office of Minority Affairs at that time, a state-level office of that. I'll talk about that a little bit more. And as we embarked upon that work, which was several years, I moved on to my current position in January of 2015, and the good work continued. And we were the Kanawha-Charleston Health Department, which is, you could see the state map in Kanawha County where the state capital is, was accredited, became the first and the only currently nationally accredited local health department in the state. And in picture, you can see the picture of the health department as well as the board members in the middle, and on the two sides, you can see the current health officer on the left, Dr. Michael Brumage, and myself on the right. So we continue to work from a local, state, community levels to ensure that the broad aspect of the work continued, because, as was mentioned by Robin, is the reaccreditation is also an aspect of ensuring that the health equity work continues to occur. Beginning in 2015, one of the things we wanted to do is take the richness of that experience and start to apply it so the benefit can occur across all the counties in West Virginia, as well as those who are contemplating pursuing accreditation. So we started with creating something called a Public Health Impact Task Force, or PHAB, and we held meetings across the state and across, including health departments, but also then including the public health system at large, which we know includes a lot more than governmental public health, payers, legislators, charity clinics, the primary care system, hospital systems. So there was a multiple public and private sector partners that were involved in this, with the goal of, as you can see, ultimately improving health, but going through improving quality and reducing cost. But for that to happen, having the prerequisite of having a supportive and enabling public health system that can understand both the social determinants of health, as well as the ability to impact the health inequities across the system. So as we develop the pillars, including the value-based systems, data analytics systems, traditional approaches, innovation in patient-centered care in the community level, we also ensured that health in all policies approach was critical as a pillar to that in order to achieve some of those equities in the long term. And therefore, one of the things we did is using the same model, embarking upon at the state level to start the process of accreditation, we had a regional area that you can see the state map with the green highlighted. It's called Mid-Ohio Valley Health Department. That's the only regional health department. So we actually embarked upon our academic partners, the College of Business Economics, to help us conduct a research study and economic analysis of what would the impact of causing structural changes across West Virginia in terms of local governmental public health system look like in terms of impacting inequities as well as saving dollars. And that result was also very helpful in us moving to the next step. But one of the things we also had, because of years ago we had the Office of Minority Affairs at the governor's office level, we had created an Office of Minority Health. So we've now begun the process of evolving the office into at a state level into the Office of Minority Health and adding the term health equity. So we can, as was discussed by Liza a minute ago, looking at institutionalizing the concept of health equity from a state level down, so we can actually start to think across programs and across offices and across systems as we approach accreditation. So as we prepare for accreditation at state level, what we're trying also attempt to do is continue the health in all policies concept to address health equity in terms of social determinants of health and providing acceptability to service and care to people all across. One of the challenge and one of the discussion points we've had is your zip code should not define the ability for you to get governmental public health service levels in the state. So wherever you live, regardless of zip code, you should all be able to get a certain level of services in terms of volume, access, quality, and all of those things. And that's why we're working with a number of local health departments now to continue the accreditation process, but also ensure that there are standards, accountable systems in place that would provide those services with the ultimate aim of reducing disparity, health disparity, but improving and enhancing the health equity, which will obviously, as we know, yield improved health outcomes. So that's kind of the model we're utilizing in West Virginia, having the experience of one of the health departments obtained accreditation, having several others now in various stages of accreditation, embarking upon the process to have state-level accreditation achieved as well. So that's where we are currently, and we're certainly seeing health equity is a very important piece of becoming accredited in our state. So thank you very much for listening.
Thank you so much, Dr. Gupta. It was really great to learn about how local health has been an important partner in this work, and it was really interesting to hear about how the State Health Agency was partnering with local, public, and private partners to advance health equity and accreditation through the Public Health Impact Task Force. So thank you so much for sharing all of that. Our final presenter is Kristen Sullivan, the Manager of Public Health Systems Improvement at the Connecticut Department of Health. Kristen has significant experience in public health administration, and in her current role, she's responsible for ensuring coordination and support in meeting national accreditation standards, quality improvement and performance management, strategic and state health improvement planning, administration of the Office of Health Equity, and SIM population health planning. Kristen also played a key role in the Department of Health's recent designation as an accredited state health department. Kristen?
Great, thank you very much. And thank you for the opportunity to share Connecticut's health equity and accreditation experience. We are really proud to be a recently accredited state health department, and we're also proud that health equity was recognized as one of our greatest strengths during the process. My presentation, I think, will show a practical approach and how our health equity work advanced accreditation and vice versa. So let me start with this slide, which shows our major milestones in our health equity and accreditation journey that I think really went hand in hand. Our work in health equity started long before our accreditation activities. In 1998, legislation established an Office of Multicultural Health at DPH, and it was updated in 2014 to be called the Office of Health Equity. But the legislation prescribed activities of the office, such as conducting disparities assessment and the development of statewide partnerships to address disparities. And by 2009, we had 2 health disparity reports published and a multicultural health partnership already established. So this sort of history of looking at disparities and the factors that contribute to poor health outcomes carried through to and prompted a really strong focus on health equity in the development of our prerequisites for accreditation. We did start accreditation in earnest in 2012, and you can see there was a lot more activity from that point forward on the timeline in terms of getting internal health equity policies and programs in place. Our health equity director at the time noted that accreditation was really helping with the collaboration and cooperation in getting some of those pieces in place. As part of our goals of accreditation and improving population health, Connecticut placed a strong focus on building a culture of health equity. And one of our approaches was to insert health equity into major planning and policy development activities. Specifically, our strategic plan, our SHIP policy agenda, our performance management system, and our workforce development planning. So for example, our current strategic map is on the screen, and we've maintained a cross-cutting focus on championing a culture of health equity. You can see it with the red arrow down at the bottom. This year, we made a concerted effort to include a strategic priority tied to our SHIP that focuses on reducing disparities in chronic disease, environmental health, and injury. That's column C with the yellow, green, and red boxes. And then some other priority objectives we included that support health equity is engaging new partnerships. That's column A in the turquoise box. And enhancing data capacity. So that's column B with the blue boxes. The first year that we did this, though, back in 2013 when we developed our first strategic map, that whole concept of a strategic map and a culture of health equity was very new to staff. So we met with programs to discuss how their work supports the strategic priorities of the agency. And we found that they were having a lot of trouble identifying how their everyday work contributed to a culture of health equity. And it was one of the reasons why we focused on internal policy, tools, and training and really put those in place. And I'll show you some of these shortly. So these are examples of ways we incorporated health equity considerations into policy development. And the first tool that's on your left was developed by our Office of Health Equity and Government Relations. And it helps staff to assess the impact of new legislative proposals. So it prompts key questions and considerations for programs before they submit their legislative proposals. What is the impact on priority populations? Does it have an impact on the social determinants of health? Could this policy make the disparities worse? And the second example is our first ever SHIP Coalition policy agenda. And when we were building this, we asked the coalition to consider the CDC health impact pyramid and to focus on policy changes that would have the largest impact on health or those that address socioeconomic factors. So you can see, I hope you can see the 2017 policy agenda on the right. It includes paid family medical leave to support maternal, infant, and child health, adoption of a property maintenance code to improve housing, and community health worker certification to improve access and quality of care. There's other policy agenda items, but those are a few that I wanted to call out that really get at those socioeconomic factors. So this is an example of how we incorporated health equity into our performance management system, which we use to measure and track all our SHIP objectives. And for example, our lead dashboard, and it's circled, it's on the left-hand side. This is our dashboard on the left. The lead dashboard is circled, and then each of these dashboard areas have a health disparity dashboard now. And so, for example, our lead statewide prevalence rate is approaching our target. It's low. We're looking great. But our disparity dashboard, which is to the right, if I clicked on that disparity dashboard under environmental risk factors and health, it would bring up this dashboard. And that shows quite a different story, that Black children have more than twice the rate of non-Black children. And we know that in order to further reduce the overall prevalence rate, that this disparity needs to be addressed. So this is open to the public. This is our partners, and our public can see these dashboards, especially the health disparity dashboards. And we're working with our SHIP teams to incorporate review of the disparity dashboards before updating their implementation plans later this year. And finally, these are examples of how we support health equity through workforce development activities. We know leadership skills are part of health equity competencies and also connected to empowerment, quality improvement, and culture change. Connecticut DPH has invested in leadership development training since 2013, and we're now on our 10th cohort, I believe, going through the training. And it's based on the Leadership Challenge by Kouzes and Posners and the 5 exemplary practices of leadership. Our other health equity training is part of a mandatory training plan for new employees, and we also provide an in-person health equity module. Both are part of the new employee orientation and onboarding program as well. And then on the right is a health equity toolkit. This is on our agency intranet, and it's to help staff with building a culture of health equity. So besides background information and definitions to build a common language, it includes tools for staff such as the legislative worksheet I showed earlier, but also a grant application worksheet and a health equity planning guide for new projects. So all of those tools generally assist staff in identifying the impacts of the proposals, the populations that they're targeting or that they want to target, disparities they are addressing, collaborations with partners, and ways to modify the proposals to make sure that disparities are not made worse. So I just want to address some of our strategic partnerships and one of the initiatives we have going on with this, because I think strategic and unique partnerships are critical to advance health equity given the complexity of solving some of these problems. Many of our current partners are a part of our SHIP coalition and the Multicultural Health Partnership that I referenced earlier. And these include more of our traditional partners and stakeholders. Our programs were recently surveyed for partnership strengths and gaps as a part of our strategic planning. And a strategic partnership plan is underway, which may include outreach to specific state agencies, payers, healthcare sector, faith-based organizations, community health workers, business and municipal leaders. And largely those groups were identified as gaps for some of our programs. The other one that I want to mention is one of our newer partners connected to us by Commissioner Pino. They were not part of the partnership survey, but it's a community development financial institution called Connecticut Green Bank. And they're a quasi-public agency created by the state legislature, and they use limited public dollars to attract private capital investment in clean energy products. It's in its initial stages, but we're really excited about it. It's one of those unique partnerships that we want to try to attract. And we're excited to be exploring with them the feasibility of a model for energy burden reduction and health and safety upgrades to residential and multifamily housing in low to moderate income communities. And what we'd like to explore is the connection to improved health outcomes, potential cost savings to the healthcare system, and a potential return on investment that may be attractive to other public and private insurers. So hopefully more to come on that. It is in its initial stages, so I can't share any outcomes, but we're really excited and really want to start thinking about some of those unique partnerships like that. Just some parting thoughts. Accreditation really helped to get key internal health equity programs and policies in place. It was really part of that impetus. and several things that can really help, that we found that can really help to promote a culture of health equity. Engagement of staff and partners in your strategic planning and your culture change activities, tying all your major plans and performance management system with that common thread of health equity, I think really helps staff to see how their everyday work can contribute to health equity and to the bigger picture of improving health. I think leadership development plays a critical role in our culture change here, advancing quality, performance, and now we're starting to look at innovation and ways we can do that. And I think the leadership development program really is a springboard for that. Tools and checklists are extremely helpful for staff. It prompts them to consider health equity in their everyday work. And finally, I just want to say that we realize our journey hasn't ended. It's just a new beginning of a different phase. And I think to really advance health equity will require us to keep a continuous improvement mindset that we gained by going through the accreditation process. So we hope to keep that going toward this goal of achieving health equity. So thank you.
Thank you so much, Kristen. Congratulations on becoming accredited. There's a lot of great work going on in your agency, and I think these examples are extremely helpful for those on the call. And we already received a lot of questions if these slides are going to be shared, so it seems like people are really interested and excited about the work taking place in your agency. So thank you for sharing. At this time, we have time for a couple of questions. We ran a little bit over, but I think the information was extremely helpful. I'd like to ask our operator, Isaac, just to quickly explain to those on audio how they can ask a question through the phone, and after that we can start with a few questions that have come through the chat box.
Absolutely. If you'd like to ask a question, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question. We'll pause for just a moment to allow everyone an opportunity.
Thank you so much, Isaac. I'm going to go ahead and start with one of the questions that we've received through the chat box. And this, I think it's specifically for Robin, but if any of the other speakers have thoughts on this, please feel free to jump in. The question is, does the Accreditation Board consider health equity data to be just data about social determinants of health, or does health equity data also refer to data about risk factor prevalence, disease frequency, and outcomes stratified by groups suffering disadvantage? And I'm happy to repeat as well if you need to.
Sure. We consider that health equity data, but I think that we're looking for other kinds of data other than just the frequency of illness or diseases, and where those where the frequency is higher in the community. We're looking at around health equity. We're looking for health departments to take it to the next step. To now that we've identified these disparities, what in the communities or in the state are creating these disparities? So if it's lead poisoning, where's the lead poisoning occurring, and what's causing it? So is it the age of the housing stock? Is it lead in the dirt, and sometimes lead appears in the dirt and children pick it up in playgrounds? So it's looking at the broader issues and also looking at the community assets of who can we partner with to address some of these things. So yes, we do look at disparities data when we look at health equity, but I think PHAB is looking for health departments to take it to that next level, to what about the community that is causing these disparities and contributing to them that we can address on a policy level or a systems level, or those issues that I talked about in one of my early slides, the institutions, the systems, the inter and interpersonal relationships. What are data around those that we can use then to develop health equity interventions? So I hope that answered the question.
Thank you so much, Robin. That was a really great answer. I wanted to open up to the other speakers just to see if they had a couple of thoughts on that before moving on to our next question. All right. I want to open it up to the phone lines. Does anyone have a question through audio?
There's no questions at this time, but once again, to ask a question, please signal by pressing star 1 on your telephone keypad.
Thank you so much, Isaac. We'll do one more question. I know we're at 3 o'clock, but just want to give an opportunity. And this is a question about the different types of health equity and maybe some of the states, or Liza and Robin, through your experience, if you have an answer. And aside from race and ethnicity, what we have experienced working with some territories and states is that we're working with homogeneous populations. And I'm wondering if you have any thoughts or some tips for those states who have homogeneous populations to engage in health equity activities.
Well, I'll just say we've received, this is Robin from PHAB, and we have received questions from health departments like that, you know, we have a very homogeneous population. How do we identify disparities? And I would say that there are two points that I could make, and one is that I'm sure that there are pockets where some health issues are more challenging than others, whether it's tobacco use by teens or health issues that the older population has, but I'm sure that there are specific groups of populations, even in that homogeneous environment. There are groups of populations that have specific issues with which they deal that the health department can look at from a health equity perspective. And the other, and this maybe doesn't relate to states so much, but sometimes if it's a small health department or a small county, or we've dealt with this with tribes, and they say, well, our whole population has an inequitable poor health status and disparities. Well, that provides the health department in some ways, I don't want to say easier, but an easier way to sort of grapple with what are the issues in our community that are creating these disparities that are across our entire community, that our entire tribe has a health disparity that the counties around our tribe do not have. What are the issues in our tribe? And it's almost less of a challenge than to change some of those community-wide systems issues, institutional issues and policies, because you can say, well, for the tribe, we're going to change this policy, and it's going to impact on everyone in our tribe. So those are the two kinds of situations that we see from health departments that say, look, our population, it's pretty homogeneous, and it's hard for us to identify health inequities. But I would say that there are always going to be pockets, and whether it's geographical pockets or groups of the population that are going to have a higher risk for poorer health outcomes in some particular and specific way.
Yeah, and this is Liza. I just want to add to what Robin said by really recommending that we consider, when you think about what the population looks like, to be thinking about all the different aspects that might contribute to health inequities. And it's maybe, there might be maybe a bit more homogeneous in terms of race or ethnicity, but then there's also gender and gender identity and age and disability. There are so many aspects of health equity to consider and health disparities to consider, and then certainly it's health equity really needs to be, I think, thought about in a very broad way.
And just to add to that, in Connecticut, we actually have specific population groups identified in our legislation, and just like Liza mentioned, it's not just race and ethnicity, but age, gender, socioeconomic position, immigrant status, sexual minorities. We even look at different population groups like veterans, homeless, and by disability as well. So I'd be happy to share any of that with you if that would be helpful.
This is Ron.
Great.
Just to add, that, some of the thoughts also to add things like housing, things that are beyond that necessarily public health doesn't often think about, but things like open spaces, housing, transit, those are other things, parks, that also impact some of the inequities.
Thank you so much to all of our speakers for that great answer. A lot of different things to think about. And we are over time, and I do want to be respectful of everyone's time, so thank you for those of you who have stuck past the hour. First, we would love to thank all of our speakers who are on the call today sharing some great information, some great examples and experiences, and I think that this has been really helpful. Thank you to all of you who called in and participated on the webinar. We hope that you found this beneficial. And in that sense, many of you are performance improvement or quality improvement staff, and so you know that evaluations measuring success is important. And for ASTO, we want to make sure that our webinars, our resources are valuable for you, and if there are any opportunities for improvement, we would like to know that so we can make those improvements moving forward. We do have an evaluation that is on the screen, so if you want to copy that down, hopefully when we send out the slides, you can click on this link. If not, please copy and paste into your URL space. We would really appreciate your feedback. This is, again, really important for us so we can make sure that our resources are as valuable to you as possible. With that, Claire and I say thank you so much again for participating and sharing. We do have your questions for those of you who we didn't get them to our speakers, so hopefully we can share them with our speakers and maybe get some feedback in writing to share with the group as well. So thank you all so much. Have a great rest of your day and a great weekend.
Thank you.
Thank you.